Okay, today I'm going to talk about presbyopia, which is part one. In part one, we're going to take out the introduction of presbyopia, theories of how accommodation, we think about theories of accommodation, and the types of presbyopia, basically, and causes of the presbyopia, and another thing. In second part, we'll make a good discussion about techniques of measurement of ad in case of correcting presbyopia. Okay, so let's move forward. So definition: presbyopia is coming from Greek word which means presbyos means old man and ops means see or sight basically. So basically definition of presbyopia: gradual irreversible decrease in amplitude of accommodation as expected with age. What do you mean by age expected with age? It means it's a normal physiological state. Presbyopia is not at all pathological, it's only normal physiological state. Okay, so definition: eye crystalline lens loses elasticity by as the age and it's happened in the old age. So this is the most accepted theory, which is crystalline lens become hard, and that's why presbyopia happens. So in this case, I can see this TV, which is far distance, which is clear, and the remote is near, which is definitely blurred. So amplitude of accommodation with age definitely varies, and with increase in age, amplitude of accommodation decrease. To become zero is like variables. Accommodation becomes zero. See, this is Donner's table. It says 75 is the age at which accommodation will be zero. But in case of Duan's standard curve for accommodation diopter, which is definitely accommodation decrease rapidly, and after 5660 it becomes stable throughout the years, but we don't know. Let's not delve into it deeply. Okay, so in this graph we can see in x-axis is age and y-axis decreasingly increases in centimeter, and this is the zone where presbyopia is there, which is approximately at 40s, isn't it? So this is recession of near point with age. So one of the common viva question for a student is always what is the difference between presbyopia and accommodative insufficiency? Presbyopia is a physiological insufficiency. It's not that 40 years of patient has 40 years of patient's accommodation. Okay, but 20 years of patient in case of accommodative insufficiency doesn't have 20 years of patient's accommodation of amplitude. They have less than that. That's why accommodative power of a significant less than the normal physiological limit of a patient's age is accommodative insufficiency. But in case of presbyopia, it's good, but it's definitely less than necessary. Necessary means what? Less than necessary of reading distance. But presbyopia is physiological, not at all pathological. And another difference is in case of accommodative insufficiency, asthenopia is prominent. What's definitely presbyopia has early presbyopia definitely has asthenopic symptoms, but not that prominent. And symptom decreases in near visual acuity is prominent. In case of presbyopia, symptoms of decreasing near visual acuity is more prominent. But and definitely presbyopia is old age disease, and accommodative insufficiency you can see accommodation insufficiency a lot of time young children and young adults. Okay, so in terms of pathophysiology, why presbyopia happens, there are two theories. There is one theory related to lens, that is lenticular theory. One theory is related to extra lenticular theory, for example, ciliary body, zonules, and all these things. So in case of lenticular theory, the very much famous theory is sclerosis of nuclear lens of the tissue. Basically means the crystalline lens is being sclerosis, being hardened. And another theory is decrease the distance between ciliary muscles and the lens equator. And another basically concept is lens capsule with age becomes thicker and less extensible and brittle. So this is the lens capsule, this is distance between lens, and this is the most accepted is sclerosis of the new lens nucleus. But extra lenticular theory, which states the age-related hyalination of the ciliary muscles process and ciliary muscles itself, ciliary process and ciliary muscles itself, which causes the weakening of the ciliary muscles at the contraction. So that causes the loss of elasticity at the jonules too. Another theory is loss of elasticity of jonules and decrease in resistance of the vitreous humor against the accommodative lens. I don't know about this, but this is also one of the concept of extralenticular concept of pathophysiology, why presbyopia happens. So there are some theories that state why accommodation happen, and the theory, the famous three theories, that is Helmholtz theories, Sacher theories, and catenary theories. they state accommodation, how accommodation happen, and with the help of accommodation theory we can at least comprehend the idea of presbyopia, isn't it? Just let's go shortly about these theories. So first is Helmholtz theory. So Helmholtz theory states that ciliary muscles contraction ceases. So after ciliary muscles contraction ceases, the posterior zonal fiber pull and ciliary muscles backward. At that, increase in tension on the zonal fibers. So after that, increase in lens diameter and decrease in lens thickness and flattening of the anterior and posterior corpus surface. That overall causes decrease in optical power. At the same time, if we think mm, ciliary muscles contraction increases, not ceases, if it contracts in this second picture, what happens? These zonules are a little bit flaccid and the lens takes a more round shape, which means the optical power increases, which means accommodation happens, isn't it? This is the theory by the Helmholtz theory. And Sacker's theory is also like that. Ciliary muscles contracts, equatorial zone tension increase, and anterior posterior are simultaneously relaxed. Central surface steepens, especially central anterior surface steepens. That's the same. Its theory is more close to Helmholtz theory, isn't it? And then accommodation happens. So presbyopia results from the growth of the equatorial diameter of the lens. This theory suggests, with age of the perilenticular space is reduced, the ciliary muscles contraction no longer tense the zonules. So ciliary muscles contraction no longer tense the zonule. That's why it's always become flaccid and all these things. Okay. So catenary theory, it's proposed by Colin, the zonular fiber functions like a support of polynomial suspension bridge and determines the natural curvature of the lens. This brings, okay, natural curvature is determined of this bridge, which is definitely given upon zonular fibers. So in this case, ciliary muscles contracts and initiates the pressure gradient between the vitreous and the aqueous compartment, and anterior capsule and zonule form a tremoline shape in hemlock surface, and eventually the steep radius of curvature in the center of the lens and steep forward in the periphery of the anterior lens, and that's what causes accommodation. But at the same time, presbyopia occurs due to increase in lens volume with age that results in reduction in response of anterior radius of curvature to the vitreous pressure gradient created by the ciliary body. So that's why it reduces the anterior curvature surface, and based on this theory, we can think that's how presbyopia is going to occur. Okay, fine. So optics of presbyopia. What is the optics of presbyopia? Basically, in case if we have the lens and crystalline lens can accommodate so well, then near diverge light can, and due to accommodation, light directly focus on the retina. But when divergent light comes and the crystalline lens fail to accommodate, fail to become more round, then it's not focused, or image is not focused on the retina but definitely back of the retina, which means the presbyopia, isn't it? That's a simple concept. So types of presbyopia, what are the types of presbyopia? There are a lot of types of presbyopia. So let's see, this is like 6: functional presbyopia, incipient presbyopia, premature presbyopia, nocturnal presbyopia, manifest presbyopia, absolute presbyopia. Let's move in a grossly but speedy manner. Okay. So incipient, the term incipient itself not matured, isn't it? So incipient means borderline, beginning, early pre-presbyopia. So early stages when symptoms of difficulty are first encountered in the near and more difficult in dim illumination, while we can do bright illumination. That's a common symptoms that people tell you that it's a little bit difficult in a dark, dim room, but I'm perfectly okay at bright illumination. That's incipient presbyopia, which means it's not wholly manifest presbyopia, but it will definitely going to be presbyopia. It's a very early stage, incipient. Okay. So incipient presbyopia, patient history suggests the need for the reading aid, but patient perform well visually on testing and give the choice, may prefer on the remain you don't force patient incipient presbyopia. If they want, they will take reading classes. If they don't want, don't force them. When they realize, they will come and they will buy the glasses by yourselves. You're okay. So then, because They're on and off. Sometimes they feel better, sometimes they feel worse with the illumination and all the things. So incipient presbyopia, don't force them to take glasses. Okay. Functional presbyopia, when faced with the gradual decline of amplitude of accommodation, the continued near task demands, adult patients eventually report vision difficulty. The interaction between the patient's amplitude of accommodation and the patient's near vision demand is critical. So, age at which presbyopia becomes symptomatic varies due to the variation of the distance, vision status, environment, task requirement, nutrition, and disease state. There are a lot of things that matters, isn't it? And recently admitted patients in ICU and a lot of things, they uh, tend to complain the presbyopia when, especially they are in 40s, because healthy body and weak body, it definitely reflects on their near vision. So functional presbyopia means it's simple normal presbyopia with declining of amplitude of accommodation. Okay. So premature presbyopia, that's important. Presbyopia occurring at the earlier age than expected. Normally we expect 40 to 45, but they occur earlier. Okay, usually associated with the ocular disease. That's very important for example like uveitis, and nutritional deficiency or ingestion certain drugs. So uncorrected hyperopia is the major factor you have to see in your clinical practice. Okay, so premature sclerosis of crystalline lens, it can be there, but premature presbyopia, you must know there is status uncorrected hyperopia, premature sclerosis, ocular disease, or there are some other immunological conditions. That's important. So nocturnal presbyopia, which is very funny term. So night presbyopia, near vision difficulty results as an apparent decrease in accommodation in dim light. Basically, that's in dim light, uh, prescribing people have always difficulties. The increased pupil size and decreased depth of focus, that's the great concept. Usually responsible for the reduction of range of vision of the dim light. See, if light increases, pupil size decreases. If pupil size decreases, depth of field increases. And if depth of field increases, people don't need that much of aid. That's why many case patients age is 60 and they don't need 3 diopter aid, they need 2.5, sometimes 2.25. It's very important that people, as an especially optometrist, just watch the reflex of through retinoscope and judge at the same time people's diameter. It's very important. Okay. So manifest presbyopia means presbyopia with some amplitude of accommodation. Absolute presbyopia means presbyopia with amplitude of accommodation is completely absent. It's very simple term, isn't it? Manifest and absolute. Okay. What is the risk factor of the that causes the presbyopia? Age. Definitely, we always think 40 and 40 after, but another very important is hyperopia. You have to understand, if people have hyperopia and they didn't correct their hyperopia for maybe 15 years, 20 years, and all these things, and they accommodate all the time, and they need presbyopic correction far earlier than the normal immetropic patient and all these things. Okay. So near vision demand occupation for like watchmakers, or like uh, patient who reads a lot. So mobile phone makers, all these things. So their occupation needs near vision demand, and at that case, since they use all the effort of near vision, they use ciliary muscles a lot of time. There is a high chance they become presbyopic earlier. Gender, it's said that earlier onset in female. I don't know, but yes, definitely they said that. So ocular disease or trauma, so removal or damage of lens, general or muscles, or basically uveitis patient, especially intermediate uveitis, you see presbyopia a lot of times. So systemic disease, diabetic mellitus, multiple sclerosis, cardiovascular accident, vascular insufficiency, myasthenia gravis, anemia, influenza, MLS. These all cases. Just remember, you can see presbyopia earlier. Drugs like heavy alcohol consumption, clonazepam, and these all drugs can cause premature presbyopia. Okay, so heterogenic scatter or laser photocoagulation can cause sometimes. Geography, prominent at the equator, high average temperature in, because of exposure to ultraviolet radiations. Others, poor nutrition, become depression, sickness, ambient temperature can cause presbyopia earlier. So that's other thing. So basic symptoms is always like that. So my arm and not enough to see anyone. I have to hold book farther away. A newspaper is not what it used to be. It's blurry. So there is always that symptoms, isn't it? So blurred vision and the inability to see fine details at the customary near work distance is very. And other common symptoms are delay and the focusing at the near distance, ocular discomfort, headache, asthenophobia, neck and backache, redness and watering, fatigue and drowsiness of the near work, increased walking distance, near need for bright light reading and squinting and diplopia. So basically, these all are because of sign of reduction of amplitude of accommodation. So these are all things you can consider: back pain and drowsy, and you have to stress and all these things. But it's completely okay. So the basically vision in the presbyopia, distance is good, intermediate is blurry, near is far blurry. So that's the concept of presbyopia. So basically, that's the concept of presbyopia. We are introducing it. We know types, we know theory of accommodation, and all these things. So, next video, we will definitely going to discuss about the methods of measurement of ad, how we define the ad. So, in reference, I use this material, Clinical Procedure Optometry by Bartlett, and definitely Boris is my all-time favorite, and primary eye care optometry book too. Okay, bis dann. Tschüss.